Hi, good night. And the video of today is about the mental health and migration. So the main points of the readings of this week is more like analytical because the readings place migration not simply as a change of address but as a multi-stage psychosocial process of the pre-migration, during migration, and post-migration that reshapes identity, risk exposure, and access to care. So they argued that mental health outcomes among migrants are determined by a dynamic interplay of individual vulnerabilities like past trauma, premorbid personality, substance use, and structural exposures like poverty, unemployment, definition, discrimination, and social buffers like family and community support, co-ethnic networks, languages, and skills. So the others emphasize that some groups like refugees, detained, asylum seekers, migrant for very dissimilar standard receiving cultures, face distinctly higher burdens of PTSD, psychosis, and common mental disorder. But more important, not all migrants fare worse. Protective factors and context matter, and the text also stresses system level responsibilities, culturally competent services, interpreted training, and multi-sectoral supports. Housing, legal aid, and employment are central. The main, meaning. Oh, this word is difficult. Two, meaningful recovery and integration. Yeah, as you know, I am a student of Mexico, and we have to talk on the videos in English, and sometimes it's so difficult, but not impossible. So we're practicing. And the second point of the readings are what wasn't clear or confusing, and how to resolve it. So they have one point more specific and actionable. Like two areas fit under as specified in the chapters. First one is causal pathways versus correlation for psychosis risk. So several meta-analyses and core studies show increased psychosis risk in some migrant groups, but the mechanisms, social defeat, discrimination, biological stress, sensitization, or selection bias, remains debated. To clarify this, we need longitudinal study that measure discrimination, social network size, and substance exposure, and biological stress markers before psychosis onset, and meditation analysis to switch pathway explains that exists risk. And the chapters point to hypothesis social dopaminergic sensation, but do not present decisive longitudinal mediator data. And two, or the point two, is how to operationalize cultural competence. It has to recommend cultural competence and interpretive services, but are also less concrete about training, curricula, measurable competences, or systems for evaluating and interpreted fairly and confidentially. So concrete next step will be standardized competency-based curriculum, like learning objectives, assessment rubrics for clinicians and interpreters, plus routine service metrics like proportion of encounters with accredited interpreters, patient report experiences measures. And specifically, this chapter notes the issue but leaves implementation design open. So the point or the number three is what was new to me and changed how I see things. It's just more like irreflectively or so unclear why. And I was struck by two insights that changed my mind on my way of think. One is the 10 to 12-year gap in pigmental islandness after migration. It's the idea that migrants may show low islandness early after moving, but face recent mental health problems are a decade later reframes how I think about follow-up and prevention. It means short post-arrival screening and insufficient services should play medium, long-term outreach and monitor social trajectories, employment discrimination, and family separation that surface later. This challenged my prior mental model that race is concentrated immediately after trauma or arrival. And the second is protective role of ethnic density is complex because about this I learned that living in a co-ethnic enclave is not uniformly productive in some contexts, and it buffers stress. In others, it may be associated with poor resources or social isolation. That nouns that may not assume ethnic community it's equal automatically protective, and to look for concrete indicators of social support, not just demographic concentration, and this links clinical thinking to community level assessment. So these insights connect to public health courses I've taken. Individual clinical care must be paired with policies that influence employment, housing, and anti-discrimination. And otherwise, we treat symptoms without addressing upstream drivers. And there's another question that what I would like to explore further, the reason, obviously, and the three concrete directions I'd pursue. Like the first one, mediators of migration related psychosis. Design a perspective cohort studies that measure discrimination, social isolation, and the use of cannabis, potential exposure, and biological stress markers like cortisol, inflammatory cytokines, and to test causal chains. Why policy and clinical interventions differ if the driver is social exposure versus substance exposures versus pre-existing vulnerability. And the evolution of culturally adapted psychosocial interventions for refugees. Example, problem solving, community-based models versus Western talk therapy. Because the chapters not evidence for talking therapies, but question cultural fit and comparative effectiveness trials will guide resource allocation. And 3 is the operationalizing interpreter cultural broker training in quality metrics. Why? And I think just the clinicians often report interpreted issues. Rigorous curricular and outcome measures could reduce diagnostic error and improve trust. The text modes of interpreting, like psychotherapeutic, linguistic advocate, cultural broker, were operationalizing and into training models and quality indicators. And finally, the last question is one specific personal professional example linking to this week's readings. During a primary care rotation, saw a middle-aged woman who had recently migrated and presented with multiple somatic complaints like headaches, abdominal pain, sleep problems, So these symptoms are so common, and the only people in it. So she used a noun accented, interpreted only intermittently, had unstable housing, and had lost her job. Initially, the care team considered a purely biomedical workup, reflecting the readings, recognized cultural bereavement and is like acculturative stress as essential contributors, because loss of role, financial strain, language barrier, and shame about job loss. So we adjust the plan, arrange a trust interpreter for full psychosocial history, connect her with a community organization for job search help, and organize a short problem-solving therapy referral. And then our amount of somatic complaints probably resolved. It's like, whoa, this case mirrors the chapter's emphasis that practical multisectoral supports employment, housing, community connection, therapeutic, and not just psychotherapy or medication alone. In general conclusion, migration reshapes lives across biological, psychological, and social domains. These readings force clinicians, public health practitioners to look beyond immediate arrival era trauma and to plan for long-term trajectories shaped by discrimination, employment, social support, and culturally mediated help seeking. And if effective care requires skilled, humble clinicians, high-quality interpreter, and community partnerships and policies that reduce structural inequalities. In short, treating migrants' mental health is both clinical and civic work. So never forget this. And the references or 7 citations that are down below on the video. And thank you so much for watching. See you in the next week.